5 in our series, Money Talks, Economics and Public Policy. After hearing last week about Social Security and the pros and cons of private investment accounts, we're going tonight to the other end of the scale and think about the economics of poverty. Christina Paxson, who will be our guide tonight, did her undergraduate work at Swarthmore and undergraduate work at Columbia. She joined the Princeton faculty in 1987 and today is Professor of Economics and Public Policy and Associate Chair of the Economics Department. Professor Paxson has the distinction in this series of having had both her first and her last name misspelled in our brochure, which I think may be a personal best for us. As one of several presumably blind proofreaders, and on behalf of the adult school, let me publicly apologize. This is the correct spelling. As the founding director of the at Princeton of the Center for Health and Well-Being, Professor Paxson focuses her teaching, research, and writing on her interests in health and economic development. Particularly appropriate, therefore, that the subject of her talk tonight is growing up poor, how poverty affects children's health, development, and economic prospects.
Thanks very much for inviting me. I'm delighted to be here. It sounds like a great series. I was trying to decide how to focus this talk, and I looked over all the other lectures that you're having, and I decided to focus pretty squarely on health, which I think is a pretty important issue. You have a couple more talks on health coming up, and I thought that to set the stage for the talk today, as well as maybe some of the ones that are coming, I know my colleague Ray Reinhardt, I think, is speaking next week. I thought it would be useful to consider a few statistics about the state of health and healthcare in the U.S. And it'll sort of frame where I'm going to go in the next hour of talking. In 2001, the U.S. spent about $4,900 per person on healthcare. Healthcare spending comprised 13.9% of our GDP, and this has gone up since 2001. So that was around the turn of the century. This is actually the highest level of healthcare spending of any industrialized country in the world. The country with the second highest level of spending is Switzerland. It spent about $3,300 per person, or 68% of the U.S. spending level. Canada and Germany spent about 57% of the U.S. level. And these countries obviously also devoted smaller shares of their GDPs to healthcare. This is not due to the U.S. having an older population. There's no sort of obvious reason why we should be spending a lot more. Now, the thing that's kind of interesting is while we spend quite a bit, we have as a population poor health relative to other countries at similar income levels. So, for example, our life expectancy in the U.S. is 77.2 years, which is, despite our much higher levels of spending on healthcare, slightly less than the average of all OECD countries. We also have higher than average rates of mortality. So when you look at the picture overall, simply put, you say, we don't get a lot of help for our healthcare spending. So what's going on here? One thing you could do is draw the conclusion that we have lousy healthcare in America. I think drawing this conclusion would be a big mistake. We actually have really amazing healthcare in America. The U.S. is one of the main sources of new medical technologies. They spread across the country. They benefit the entire world. We have really highly trained doctors and health professionals who are in the business of treating people. The big problem I think that we have is that not everybody has access to great health care. So there are huge disparities in access in the country. Furthermore, we often do a very bad job at helping prevent diseases and conditions that lead to poor health and higher mortality later in life. What I want to focus on in this talk are the roots of disparities in health and focusing on children. But let me tell you, sort of as an economist, how I got to this topic. So I think it is kind of a slightly unusual topic. It's slightly out of the mainstream of traditional economics, although there are a lot of people working on it right now. Let's first think about what's going on in disparities in health among adults. If you look in the mid-1990s, and let's look first at racial disparities. The life expectancy at birth for a white man was 73.9 years. The life expectancy for a black man was 66.1 years. So about a 7.8 year difference gap in years of life that someone can expect to lead. The gap between white and black women was about 5.5 years, 5.5 years. Now, most of the research out there indicates that these disparities in racial disparities are really masking economic disparities. It's not race per se that matters here, it's differences in income levels that really drive these results. So for example, what do we get if we look at income? Well, there was a study that looked at people, men who are 25 years old in 1980. So these are people who would have been late middle age now. White men at the age of 25 who are in the lowest income category can expect to live 10 years less than those in the highest income category. So as an economist, when I hear these sort of numbers, and I remember the first time I heard them, I thought, yeah, this is really striking. As an economist, we think of money as buying, you know, goods and services. If we have more money, we can buy more clothes, more food, better houses, da-da-da. We don't usually think of money as buying years of life, right? Which is a pretty important thing to think about. So I started off doing some research on trying to understand where these disparities in health where they come about, and started working first looking at older people. And in some sense, this topic is a little bit like peeling an onion, because you sort of say, you know, why are there these big differences in health across income groups among people who are in their 50s? Well, they were there in their 40s, and they were there in their 30s. And you keep, at least I kept working back intellectually, looking at younger and younger age groups until I landed back at childhood. And I think one of the things that's been really interesting for me is to try to look at the very origins of this economic gradient in health, trying to understand where it comes from, and also the implications of it for children as they grow older. So that sort of gives you kind of background as to how I got to this maybe slightly strange topic. What I'm going to do in this talk is I'm going to focus on the causes and consequences of health disparities among children. The key issues that I'm going to talk about are, first, to show that there are large disparities in health even very early in childhood. So poor children are much less healthy than wealthier children. I'm going to talk some about the economic consequences of these disparities. So what does it mean to grow up to be a poor child in poor health when you reach the age of 25, 30, 40? Right? And then also, at the end, come back to some policy issues that I think this research suggests are important. So that's where I'm going. Okay. Let me just give you a really brief background on sort of poverty and what we mean when we talk about poverty, a little 2-minute primer on poverty. Basically, poverty is defined in this country by the poverty line. The poverty line is the level of family income below which every single person in a household is deemed to be poor. The lines vary by household size. They're updated every year by the Consumer Price Index. They were first created, you know, I think in the 60s. It might even have been a little bit earlier. And they've been with us ever since. So this will be a typical table that you get from the U.S. Census Bureau that has poverty lines. And you can see that it has, you know, family size is important and the number of children are important. But the one kind of key numbers you get from this table are just some size of what it means to be poor in America. So for example, if you have a 2-person household where the adult is under 65 years of age with 1 child, so that would be a single mom with 1 kid, the poverty line is $12,400. These numbers are 2 years out of date, so they've gone up by the rate of inflation since then. And then for, you know, 3-person, 4-person, they keep climbing up along the way. Now the thing that is kind of interesting to think about is, well, you know, when we talk about poverty alleviation programs, I think a lot of people have the naive view that when people get, quote, welfare, that brings them up out of poverty. Well, when you look at New Jersey, for example, where we all live, and we look at TANF benefits, temporary assistance for needy families, the benefit for a family of 3 is about $5,100 per year, or about 35% of the poverty line. So if someone just lived on TANF alone, that's about where they would be. Another way to do the calculations is that the poverty line for a family with 1 adult and 2 children is about $15,000 per year, and it would take someone working at a wage of $7.25 per hour for an entire year just to make that line. The reason why I'm putting these statistics up for you is to get you to think about poverty a little bit more broadly. We're not just talking about people on welfare, we're talking about a vast number of people who are working poor. Now, given these sorts of these kind of examples, it shouldn't be that big of a surprise, that the welfare reforms of the 90s didn't move, although they moved massive numbers of people off of welfare and into work, they didn't do that much to combat child poverty. Because people were moving from, not much money on welfare to low-wage jobs, probably below $7.25 and certainly below $9.15. So if you look at the statistics on poverty rates by age in the U.S., you get something like this. So this line right here shows the poverty rate for children, so people under the age of 18. 1964, Johnson declares the war on poverty. The poverty rates for older people have declined almost steadily over the period. The poverty rates for children have actually sort of just moved around, and they started around 20%, they dipped, they went back up, they came back down. When this graph was made by the Census Bureau in 2002, 16.7%, pretty close to where we started in 1964, were in poverty. And actually the poverty rate, although the fact that we weren't in a recession, the poverty rate increased slightly to 17.8% in 2002-2004. So there hasn't been a lot of action in getting children to become less poor as a result of public policy. A couple caveats I should note, which is sort of a digression, but I think it's important to know, is that when we calculate poverty rates, they're based on before tax income. So programs like the Earned Income Tax Credit or even Medicaid don't actually go into the calculations of whether someone's in poverty. So because of the EITC and because of increases in Medicaid that I'll come back to at the end of the talk, it may be that the poverty rates for children are a little bit lower than the figure would suggest, the quote real poverty rates, not as officially calculated. Okay, so I think an important question, and again, this is leading into the health topic that I'm eventually going to get to, I promise, is what are the prospects for poor children in America? So, maybe you're a poor kid. That's okay if when you grow up you have a lot of opportunity to become a wealthier adult. Social scientists usually talk about this in terms of social mobility, which is defined as the lack of persistence and economic advantage or disadvantage across generations or over time within generations. So really what we're interested in knowing is, what are your odds, what are your chances of moving from where you started, right? Well, I think, again, a lot of people have this idea that the United States is very mobile, right? People can move a lot, they move up, they move down, and we'll probably say that we're much more mobile than a lot of European societies. In fact, when you look across evidence from different countries, we're no more mobile than other societies. We're about the same as Britain, about the same as Germany, a little bit less mobile than Canada. So that, there's some opportunities for mobility, but they're not enormous. So this gives you one example. If you're born, and these are recent estimates from a paper published in 2005, if you're born in the bottom fifth of the income distribution, 45% of people who are born in the bottom remain in the bottom as adults. So this destination wealth level is the wealth level that these children would attain in adulthood. And these are based on longitudinal surveys that track people over time. Whereas 55% of the people who are born in the richest stay richest. So there's a lot of persistence, right? People who are born poor tend to stay poor. People who are wealthy tend to stay wealthy. One thing that I think is interesting is that these levels of persistence or levels of social mobility vary a lot across racial groups. So for example, if we compare whites and blacks, whites born in the bottom quartile, this is a different paper and slightly different definitions of how you categorize income, 32% stay in the bottom, appear in the bottom as adults. For African Americans, 63% of those born in the bottom stay in the bottom as adults. The figure that I think is actually even more interesting is what about downward mobility? What's the likelihood that you're born wealthy and you end up as an adult not being wealthy? And here, 45% of whites born in the top stay in the top, and only 15% of African Americans who are born in the top part of the income distribution manage to stay there as they grow up. Which I think is a rather striking statistic. So what affects social mobility? There's a vast amount of research in social science, both economics and sociology, that tries to look at, what determines a child's life prospect? Why does a poor child stay poor versus experiencing success as they grow older. And there's sort of a large laundry list of things that people have talked about as being important for social mobility. Inheritability is surely part of it. Family background, the kind of parenting you receive. Your educational opportunities, do you grow up with good schools, bad schools, labor markets and any economic discrimination you might face. And finally, a topic that has received some attention, although probably not as much as the first ones on the list, is health. And that's what I want to focus on now. What I want to convince you of are the following two things, and then we'll talk about implications. The first is that poor children have worse health outcomes, that there are striking disparities in health among children, even if they're born, and probably that develop from even before the time that they're born. And the second is that poor health in childhood has fairly dramatic long-run implications for success in adulthood. So the payoffs to having good health as a child are relatively large. And then we'll talk about some policy issues. Okay, so part one, poor children have worse health outcomes. I'm not going to go through an exhaustive review of the literature, but I do want to show you sort of some real statistics so you can get a feel of what kind of data there are out there. So what I'm going to first show you is probably the most general measure of health that's used in this kind of research. It's a little mushy, don't worry. If you're dissatisfied with it, I'll get to some harder statistics later. But I actually like this measure a lot. In a lot of health surveys, what they do is they'll ask people or they'll ask parents, how healthy are you? Right? And you give your a rating. You say excellent, very good, good, fair, poor. You can report for yourself or you can report for your child. Now, this seems incredibly subjective, but it turns out that among adults who say that they're not healthy are much more likely to die in the next 5 years than adults who say that they're healthy. And in addition, that's even true controlling for their doctor's assessments of their health. So in other words, if your doctor says you're healthy and you say you're not, that's bad news, okay? The other thing that's true is that these subjective ratings of health are very highly correlated with a lot of objective medical conditions that we can look at, and I'll show you some later. So the data that I'm going to show you are from the large health surveys that are conducted annually in the U.S. They're the National Health Interview Surveys. And this pulls data from 6 years. And in this survey, children were classified by parents. And let's see what we get. So here's a graph. These are based on non-parametric regressions, and I won't go into the details behind them. But basically what you have here are, on the y-axis is a measure of whether the child's in excellent or very good health. So it's the percentage who are in excellent or very good health. And here's family income along the other scale. Okay? You can do a lot of other sort of controls for different things, but it doesn't really change these results. And I think a couple really interesting points come out of this. First of all, let's focus on this line here for children who are age 0 to 2. Okay? The one thing to note is that these lines slope up. So wealthier kids are much more likely to be in excellent or very good health than poor kids. The differences are pretty striking. If you go down here, sort of in the $10,000 range, so now you're talking about kids who are below the poverty line, most likely. And even at the age of 0 to 2, about 75% are reported by their parents to be in excellent or very good health. If you go up to the way other end of the income distribution, so I chopped it off at people who earned $100,000 a year. So they're not excessively rich, but they're definitely upper class. More than 90% of children in that age group are defined to be in excellent or very good health. Now, a couple of things I think are kind of interesting that happen as children get older, and each of these lines shows a successively older age group. What happens is, first of all, everybody's health gets worse, right, as they get older. Unfortunately, this is the beginning of a progression that goes on for the rest of their lives, right? And in fact, if I had graphed this up to age 80, which I could have, you would have seen these lines just move down, right? Too bad, but true. The other thing that you see, though, here, and you see this also throughout adulthood, is that health deteriorates much more with age for people who are poor than people who are wealthy. So, for example, the decline here among the $100,000 kids is, from 90% down to, it's hard for me to read it here, but 92 down to maybe 87. This is a very small decline. Whereas you go down here and you get a very big drop, right? Again, if I had shown you this picture for adults, you would have seen this pattern carry on into adulthood with very much, quickly declining health status among the poor and slowly declining health status among the wealthy. It turns out that when you get to very old age groups, health tends to equalize again. Okay, by the time you get to people who are 100, nobody is in very good health. So it does tend to flatten out once you hit older ages. But throughout childhood and throughout the working age, this is the kind of pattern that you see. Okay, so I think I've covered most of these points. So you have what economists refer to as income gradients. These income gradients in health status, they begin very early, they become steeper. And I'll show you some other statistics, but basically other measures of health, bed days, hospital episodes, also show similar relationships to income. One thing that I want to come back to later, which I think is very interesting, is that you see very similar patterns in other countries, even countries that have universal health care. Now, this is sort of the first clue that health care and health insurance may not be the key to what's going on here. We'll come back to that later. But it's true that if you look at data from Canada and you compare it to data from the US, you get very similar patterns. The other thing that I think is important is that there are a lot of things that you could say, well, this isn't really income, it's really something else that's correlated with income. And one of those might be race or ethnicity. It's true that there are differences in health status across racial and ethnic groups, reported health status. This shows up in other data as well. So, for example, these are the same graphs that I showed you before. They're just proving children of all ages. And this top line is for whites, and then African Americans and Hispanics are the bottom two lines. They're a little wigglier because the sample sizes are smaller. Basically, what you see is that minority groups for any income level have lower health status than do whites. But the thing that's kind of interesting here is that the income gradients, the relationship between income and health, are almost identical across those groups. Okay? So there are level differences, but they don't explain the slope. Okay. So let's move on from this very subjective measure of health. And what I want to do is start with very, very early health outcomes and then sort of walk through to health problems that might affect kids at older ages. So when you think about birth outcomes, right, these are the earliest health measures that you can really get. And there are a lot of different ways to measure how healthy children are at birth. There's, low birth weight, APGAR scores, things like that. I think the most common measure that's used in this literature is low birth weight. So, for example, we define children at birth as being low birth weight if they're below 2,500 grams, that's about 5.5 pounds. Very low birth weight if they're below 15, that's about 3-something. And then extremely low birth weight, which are the really little babies. Low birth weight can be due to a couple different things. It can be that children are born, they're at the right gestational age when they're born, so they've been in utero for the right number of weeks, 9 full months, but they're small. Or it could be that they're premature. The smallest kids are all invariably premature. Okay? So there are different reasons for having low birth weight. The other thing that probably most of you know is that low birth weight, and especially very low birth weight and exceptionally low birth weight, are associated with a really large number of adverse health problems that are going to possibly follow kids through time. So, for example, we get things like cerebral palsy, blindness, lung problems, mental retardation. We've done a good job in the past 15, 20 years in coming up with treatments to prevent deaths among very small babies and in ameliorating some of these conditions. But it's still the case that children who are born small are at a disadvantage in terms of health. Okay. So in 2002, about 7.8% of children were born at low birth weight. Rates of very low birth weight are much lower, 1.5%, and less than 1% are extremely low birth weight. One thing that's interesting is rates of low birth weight in the U.S. are actually starting to move up a little bit. And the reason is that there's an increase in multiple births among women getting fertility treatments. So you actually see a tick up in the numbers, which is unexpected, I think. between low birth weight and family income. So these top bars here show the fraction of children who are born at low birth weight, and these are very low birth weight. The exceptionally low birth weight ones were so flat, they just didn't have much to graph. There's a couple points here that I think are important. One is that the poorest children, so this would contain groups of children who are in poverty, also children who are slightly above the poverty line. Rates of low birth weight are about 9%. They drop to something under 7% for middle income kids and just a little bit over 5% for upper income kids. So these are really large differences in rates of low birth weight. One thing that I think is interesting and important to point out is I think a lot of people think that health problems are just a problem of poverty. And you see here with low birth weight, as we saw with self-rated health status, that this really isn't just a poverty problem, right? Middle income kids are doing worse than kids who are much wealthier, right? And it's true when you look across a variety of health conditions that you get these graded relationships by income. So it's not just poverty that matters, or seems to matter. The differences in very low birth weight are also actually very large, but the graph doesn't really do them justice because they're swamped by these other bars. But you go from about 1.2% down to something like 0.7%. So it's a big difference in relative terms, even though it's a fairly uncommon problem. So let's think about some other prenatal outcomes and maybe things that explain differences in rates of low birth weight. So one of the really important things for, we'll come back to it later, but supposedly important things for the health of infants is prenatal care. And in particular, then starting prenatal care early in the first trimester. So again, here what I've shown you, I don't have information on prenatal care and also prenatal tobacco use is taken off of birth certificates. Birth certificates don't have income information. What they do have is information on mother's education, which is a very, very highly correlated with income. So it's a pretty good measure of economic status. And what you see from these kinds of data are patterns that look very similar to what we've seen before. So, this is more than high school, this is less than high school, this is high school degree. So very different rates in initiating prenatal care in the first trimester. With women without high school degrees, it's under 60%. And we also get pretty big differences in prenatal tobacco use, which is something that's associated with low birth weight and preterm delivery. With very few women with some college education using smoking while they're pregnant, and a much higher fraction of women without high school degrees. Okay, so I think you're probably getting the point, but I'm going to give you a little bit more data that there are these big health disparities across income groups early in childhood. What we've done is we've used a lot of different data sets to document these types of patterns for a large number of health conditions. And the thing that's kind of interesting is, with some exceptions, and I'll show you the exceptions in a minute, pick a disease. It's worse for poor kids, especially among the problems that are more serious. So let me just show you a few more pictures. These are like the pictures that I showed you before that have a measure of income along the lower axis. And again, they graph by age. So blue is younger kids, and it goes up 4 to 8, 9 to 12, 13 to 17. So actually, I put the exceptions on the top, right? If you look at asthma, you see that among very young kids, poor kids are more likely to be diagnosed with asthma than wealthier kids. But by the time they hit adolescence, this sort of flattens out. The other conditions that don't show clear associations with income, bronchitis, which is kind of flat, and hay fever, which is positively correlated with income. I think hay fever and sinusitis are probably the two conditions that rich kids are more likely to get. We don't usually think of these as being the most serious health problems in the world. The problems that are clearly related to income, hearing problems, vision problems, digestive problems, heart conditions, epilepsy, mental retardation, this is just a subset. I could have put many more up. But across these types of conditions, you get very striking patterns. Now, another thing that I think is really important, and this will lead into when I talk about the consequences of health problems for poor kids, is that poorer children who have health conditions do worse along a variety of dimensions than wealthier kids who have the same health conditions. So, for example, In fact, I'm going to show you some numbers. Let's take asthma, for example. Now, asthma is one of the most common childhood chronic conditions. It's responsible for more missed days of school, more hospital episodes than any other condition. So what I've done is I've split the sample here into children with asthma and children without asthma. And then I rank them from poorest up to richest, right? So what you see here is that, well, no matter what income group you're in, children with, and this is percentage in excellent or very good health. I'll show you a hospital episode in a second. But no matter what income group you're in, you're much more likely to be reported in excellent health if you don't have asthma than if you do have asthma. And that's true for poor kids, and that's true for rich kids, and all the way down the line, right? But the thing that you see over here is that if you look at the difference between these two numbers, they're much bigger for poor kids than for rich kids. So in other words, if you're a poor kid with asthma, that reduces the chance that you're in excellent or very good health by about 30 percentage points. If you're a wealthy kid with asthma, it only reduces the chance that you're in excellent or very good health by 18.8 percentage points. So in other words, what asthma is doing is it's doing more damage to the health of poor children than it is to wealthier children. You can do these sorts of calculations with other measures of health outcomes. So here we have the percentage of children who have a hospital episode. Well, a typical hospital episode costs maybe $5,000–6,000. So averting hospital episodes is really important from a healthcare perspective. And again, what we see is kids with asthma are much more likely to be hospitalized, but this is much more so for poorer kids than for wealthier kids. And finally, asthma is a good example, but if you look at other diseases, you get the same sort of finding. So if we look at sick days per year, now these are days that kids can't go to school because they're sick. And again, what you see is asthma results in a much higher number of sick days per year. So for poor kids, it's 3.7 versus 11.4. There's also a lot of variance around this. A lot of kids are missing 20, 30, 40 days a year. But again, the effect of asthma on missing school is a lot bigger for poor kids than for wealthier kids. Okay, so why do we see these patterns? And I think there are a couple reasons. One is that poor kids might actually just for some reason have more severe forms of disease. If they have asthma, they have it worse. That may be because of environmental factors. They may be exposed to things that make it worse, more dust mites, worse living conditions. They may have lower quality health care so that they're not getting care that's as good when they have an asthma attack. So they're more likely to be hospitalized, for example. There's also evidence that poorer families have worse compliance with medical protocols. So, you go to the pediatrician says do X, Y, and Z. Poorer people have a harder time following those than wealthier people do, for a variety of reasons. And just generally, there may be poor management of medical conditions that lead to this sort of double burden. You're more likely to get the disease, and then when you have it, it does worse things to you. Okay. So, that's part one. Part two, what are the consequences of poor health in childhood for adults? Now, this is really important, and this is where sort of the more economist in me is coming out. If we can show that being sick as a child has big economic consequences when children grow up, then what that does is it gives you a strong case, a strong economic case for trying to improve children's health, right? And so let's think about the ways that health as a child may affect attainment or success as an adult. And there are a couple different routes that people have focused on. One is on education. And I think, for anyone who's a parent, this is sort of a no-brainer. Children who are sick don't learn as well. They can't go to school as much. So having a chronic health problem may well impede progress through school and ultimately affect the educational attainment. The other thing is, putting education aside, children who are sick are more likely to be sick as adults too. So the conditions that you develop as a child may carry forward to for adult health. And there's a lot of evidence that adults with health problems are more likely to have trouble in the labor market holding down jobs. A lot of illness associated with, a lot of absences from work associated with illnesses. And these things tend to depress suppress people's earnings when they're adults. So either through education or through the effects of adult health, we might expect that childhood health has large effects on people's economic status in adulthood. So these are sort of interesting theories. How do we test them? How do we look at this empirically? Well, there's some real problems here. In order to look at the long-run effects of childhood health and adult outcomes, we really need to be able to track people from ideally the time of birth into middle age. Now, it turns out that for some reason, and maybe somebody in the audience can tell me why this is true, the Brits love to collect cohort data, right? So there are these great cohort data sets where they've been tracking people for years and years and years. So the evidence that I'm going to talk about comes from something called the 1958 British birth cohort, where a group of children born in 1 week in March in Britain in 1958 have been followed. Now they're in their mid-40s, right? So it's a real gold mine of information on what the long-term consequences are of childhood events on adult outcomes. We don't have that kind of data in the U.S. We have some small cohorts. We don't have anything on this scope or that's been running that long. So, you know, in some sense, we might be the most interested in what happens in the U.S. For policy purposes. Most of our data is going to come from Britain. The other thing that I think is an issue here is that, you know, ideally what you're trying to identify is, well, what's the causal effect of being sick as a child on what happens later in life, right? And if you were, and I may be talking to the wrong audience, if I was talking to a medical audience, and I have before, they want to see randomized interventions. They want to see randomized control trials. What they want to see is evidence where you take the children, some of them you randomize into a program that improves their health, others you don't, and then you watch them for 40 years, and you see what happens at the end of 40 years. Now, the problem is most researchers' attention span is far too short to do that. Getting tenure and saying, oh, it's coming in 40 years is not really going to work. So we don't have these sorts of long-term randomized interventions. Instead, what we really have to do is look carefully at the correlations in the data and try to tease out effects. The other thing, and so this brings me to the next thing, this is kind of hard to do, and I don't want to go into technical details, but you know, childhood health, as we've seen, is really related to socioeconomic status, which is also related to education, which is also related to labor market effects. So teasing out the effects of health is not straightforward. So this is sort of my little diagram of the model. What we're interested in knowing is how childhood health affects adult economic status, and we think that that can work in two ways. It can work through educational attainment, which has a big effect on your earnings, or it can work through adult health, which also has effects on earnings and labor force attachment. And the problem, and the reason why we have to be very careful, is that we also have a lot of other factors, you know, parenting, educational quality, that also affect these outcomes, education and this, and they're also correlated with child health. So you need pretty good data to be able to do this. I'm going to give you a very, very quick summary of results, so we have time to move on to some policy issues. So this is the kind of evidence that we get coming out of the British data. So first what we did was we looked at how child health is, and this is work that I've done with a colleague, Ann Case at Princeton, and some postdocs, different postdocs for different projects, but Ann has been my main co-author. If we look at children who had health conditions, adverse health conditions in childhood, what we find are very large effects on educational attainment, completed education. So just to give you one example of the sort of the size of these effects, and the reason why it's a little bit complicated is that the ways that education is measured in the British surveys is quite different than it would be in U.S. surveys. So talking about high school degrees for years of education doesn't quite make the same amount of sense, especially given that these were kids born in 1958. But basically, if you were to take our results and say, okay, let's look at a child who was exposed to prenatal smoke, who's born at low birth weight, and who has one chronic condition during childhood. That's not a crazy combination, given that prenatal smoking can lead to low birth weight, which can also lead to chronic conditions. So this is a very uncommon outcome. That has a really big effect on educational attainment, and education is reduced problem translates just through its effects on education into almost a 9% decline in earnings. So then we go from there and we say, okay, big effect on education. What happens to earnings and what happens to labor market participation, right? And again, what we find are fairly large effects. So controlling for these effects on education, the effects over and above the effects on education, this same child would be predicted to have 30% lower earnings at age 33. That's a huge difference. And that gets added to the 8.6%, right? So it's a big drop in earnings as a result of health problems. Now, a lot of that comes through differences in labor force attachment. So again, what happens is these childhood health problems are associated or predict less employment at age 33. And you can follow these kids up to age 32, but basically 13.6 percentage point decline in employment. That would mean that if the typical, 90% of men on average are employed at age 33, for kids who were sick, who had this specific pattern of health problems, they would be, can I add on my feet, like 77% chance of them being employed. So a big difference. Okay. This is not the only evidence out there in the world. In fact, there's more evidence out there in education because in other countries there are these sorts of data that track kids through schooling. So I think, we don't have the sort of really long-term effect evidence that we see in Britain, but we do see in the US and Canada other evidence that health problems adversely affect education. And there's some interesting evidence that mental and emotional conditions actually have the biggest effects, more than physical health conditions. Okay, so summary so far. Poor children are in worse health. Worse health in childhood is associated with lower educational attainment, less chance of being employed, lower earnings as an adult. Okay, so let's talk about policy a little bit. That is the topic of this session overall, and I haven't really touched on it yet, but I want to. When a lot of people hear health, they think health care. It's sort of a logical leap. And so a natural question might be, well, if we wanted to fix this problem, if we wanted to improve the health of poor kids, thereby giving them better prospects as adults, what would we do? And I think a lot of people would say, well, we really need to improve access to health care. And then the next leap is to say, and we do that by increasing health insurance. Now, a lot of people have taken, well, I'll say that later. We actually have a great experiment that's happened in the US over the 80s and the 90s. During that period, we actually did have a huge expansion in healthcare coverage among children through expansions in Medicaid. So Medicaid is healthcare for low-income people. It covers children, pregnant women. It also covers some healthcare expenses for the elderly, expenses that aren't covered by Medicare. During the 80s, there was and it used to be that Medicaid for kids really got with being on welfare. You got welfare, you got Medicaid, and they were locked together. During the 80s, there was some breakdown of that tying together, and more kids were made eligible on the basis of their income for Medicaid. So by 1992, all states were required to cover pregnant women and young children with incomes up to 133% of the poverty line. Well, we saw from very early that that's well above what people were getting for welfare. So this is really cutting into the distribution of working poor families. States actually had the option to do better than that. They could cover, receive federal matching funds to cover pregnant women and infants with incomes up to 185% of the poverty line. And consistent with these expansions in Medicaid eligibility, there were big consistent with these changes in policy, there were big expansions in Medicaid eligibility. So for example, by, I hate to look at the computer, I like to look up here. So the fraction of women of childbearing age eligible for Medicaid went from 17% in 84 to 43% in 92. Medicaid became the single largest payer of children's births, medical costs associated with births. Okay, now the increases in Medicaid were very interesting in that they were prompted by a real belief that doing these expansions would have very large effects on children's health. And in fact, in 1985, there was this very influential report that was issued by the Institute of Medicine that was called was cited as one of the main reasons for increasing access to Medicaid. Right? Now, go forward by 10 years, we're up to 1995, and the view about the value of prenatal care specifically has changed a lot. So, for example, there's an article in a journal called The Future of Children that I'm a senior editor on, so I'll brag about it, it's a great journal, that Cece Ralsbury mentioned it when she talked here. So here's a quote from an article in 1995. Although the general notion that prenatal care is of value to both mother and child became widely accepted in this century, the empirical evidence supporting the association between prenatal care and reduced rates of low birth weight emerged slowly and has been equivocal. In other words, there's not a lot of good evidence. Now, a lot of people are going to say after I finish my talk, and I want to make this very clear, I'm not against prenatal care, I'm not against health insurance. But the evidence on whether expanding insurance has improved the health of children has been very disappointing. So, for example, there's a really good series of papers by an economist named Janet Curry, who's now at Columbia University, and various colleagues, that look very carefully at the effects of these Medicaid expansions on the health of infants and children. And what she found is kind of interesting, and it's not, again, it's equivocal. There's some evidence that's good and some evidence that's not so good. If you look at infant mortality, it looks like the Medicaid expansions did a really good job. Infant mortality dropped by about 8.5%. Not huge, but that's a decline, and that's wonderful. Interestingly, those declines weren't due to decreases in low birth weight. They appear to have been due to expansions in access to medical technologies available to pregnant women who gave birth to low birth weight children, right? So it's the medical intervention after the birth, not the preventive care that we would have hoped. The Medicaid expansions appear to have some larger benefits for some narrowly defined groups of people at high risk, teenage mothers and others with specific health problems. But by and large, birth weights didn't go down that much despite the big increase in insurance. When we go forward and we say, well, what about child health? All these children who weren't insured suddenly are insured. Well, again, what we see is, yeah, there's some benefits, but they're surely not that big. One thing that we do know is that eligibility increases healthcare utilization. A lot more kids were going to the doctor. And they're going to doctor's offices rather than emergency rooms, which is probably a really good thing. There's some evidence that eligibility caused a reduction in child mortality. The child mortality rates in older ages are so low that it's hard to get a precise measure of that. Other evidence indicates that the medical expansions didn't lead to fewer bed days, stay sick, or greater immunization rates with a few exceptions. So again, we get very equivocal evidence. So overall, we've had this huge expansion. It didn't do much good. So what do we do? So if improving health care or health insurance doesn't do the trick, well, it will. So what I have, just to conclude, is I have 4 areas where, based on my own research as well as my reading in the literature, I think are really interesting areas to look. And we don't have a lot of evidence for some of these things, but I think there's enough evidence to make them worth checking out further. One is, well, maybe what happened was we improved access to health care, but we improved access to lousy health care. So let me give you an example that I think is a really interesting example. One thing that we know is that prenatal smoking is a big cause of low birth weight. And we also know, in fact, there's a really great, very long review article that goes through all these extensive studies, that there are actually good smoking cessation programs out there that can get women to either quit or scale back on how much they smoke when they're pregnant. And in addition, the programs that were reviewed found that when women cut back on smoking or quit when they were pregnant, it had significant effects on low birth weight and preterm birth. So there are things out there that we know that work. And these are behavioral interventions. They don't cost a whole lot of money. Okay, well, does Medicaid cover prenatal smoking cessation programs? Well, we're getting there. In 1998, only 24 states covered prenatal smoking cessation. That actually grew to 36 by 2001. One might ask why it's not higher than 36, but at least it's an improvement. But the thing that is, I think, a kicker is that there was a survey done of physicians in states, physicians that were treating pregnant women on Medicaid, that asked them whether Medicaid covered knew that they did. These were in states that had it. So, you know, so you have things that are available that actually aren't being used by women. Now, this is just one example, but I think if you go through a lot of the work that's been done on Medicaid, there are a lot of concerns about the quality of care that people receive. So it may be that improving access to health insurance is a necessary but not a sufficient condition to help children, poor children who are unhealthy, or to prevent them from becoming that way. The other thing that the evidence points to is that parents need a lot more help managing children's health problems. So for example, there's a recent study from Michigan that looked at parents who were told that their child needed follow-up after vision and hearing screening in school. So these are kids who flunked the vision screening or they flunked the hearing test. 75% of parents do so, 25% don't. This particular study didn't look at whether there were income disparities and who followed up and who didn't, but I can probably guess what the answer to that is. Which means that there are kids walking around without eyeglasses who are in school. The one thing that we do know, and there's pretty good evidence on, and I mentioned this before, is that poorer families and those with less well-educated parents, again, they tend to go together, do much well or less likely to follow medical protocols for asthma, diabetes, and epilepsy. A lot of children's health problems require a lot of work on the part of families. There are sort of complex conditions, they require management. You can go to a doctor, they can tell you in 2 seconds what to do. You have to take it home and you have to do it, and that's hard. And the sort of resources and support isn't there, especially for poor families. The other thing that I think is important is that doctors' visits may not be all that's really needed to treat very complex medical problems. And there's actually an op-ed, and I think it was in the Times a couple years ago, and I wish I remember the name of the author because I should give him credit, but it was actually very interesting. This is somebody who worked in an asthma clinic in Boston. And they told a story in this op-ed of a child who kept coming back to the clinic repeatedly with asthma. In the hospital, emergency room visits, very badly controlled asthma. And so the doctors kept, giving medicine, kept coming back. So finally what they did was they found a social worker to go to the child's house. And the social worker goes to the kid's house, and there's pipes, they're leaking all over the carpet, the carpet's sodden, it's mildewy, it's clearly not a good condition for the child to be in. So the social worker calls the landlord and says, sorry, you gotta fix the pipes and remove the carpet. The landlord says, no, right? So back to the clinic. Well, this is actually a very progressive clinic. They found a legal aid lawyer to go take the family, sue the landlord, get the pipes fixed, get the carpet replaced, and the child's asthma got better. But the reason why I like this story is it took a pediatrician, a social worker, and a lawyer to get this child's health problem resolved. So those are the sorts of services, this is an extreme case, that might be useful that I think children aren't getting. One more thing that I think is important is not all cost-effective programs are things that we traditionally think of as medical programs. So WIC, which is the Special Supplemental and Nutrition Program for Women and Infants and Children, I think is a really good example. This is a program that's been around for a long time. It offers a basket of food to poor families. It's valued at $35 per month. It also provides a range of nutrition surveys. Now, WIC has been given a bad name because they hand out formula, and so a lot of people have been concerned that what WIC is doing is deterring women from breastfeeding. And there's a little bit of evidence that that might be so. But on balance, if you look at the studies that have been done on the effectiveness of WIC at preventing childhood health problems, they're actually really, I think, quite dramatic. Where WIC is associated with a wide range of positive health outcomes, higher birth weight, less hospitalization in infants and mothers. The estimates that come out indicate that $1 spent on WIC saves much more than that in healthcare expenses down the road. So this is an effective intervention. It might be the type of intervention that we think of focusing more energy or money on. The other thing that I think, the final thing that I'll conclude with is, I hope at the very least that the evidence that I presented to you on the long-term health effects of children's health problems convince you that when we do analyses or kind of the cost-benefit calculations that go with government policies, we take into account what these long-term benefits of improving health status of children. I think a lot of people, when you say, what's the benefit of a child being healthier? Well, a lot of those benefit calculations come out with pretty small numbers. And they come out with pretty small numbers because people usually only consider the health benefits of health interventions. Particularly, a lot of people look specifically at deaths averted. Well, a lot of health interventions that improve the quality of life for kids, that make them easy, make them able to go to school, that make them more able to be successful in the long run, may not be ones that avert deaths. So the kind of calculation that you really want to do is to say, well, if we can implement this program that's going to improve children's health, then what that's going to do is result in higher educational attainment, it's going to result in higher earnings, higher tax revenue. So trying to sort of recast this to make an economic case for focusing on health outcomes very early in life seems to me to be something that we should do that we haven't really done, and continue that. So I've been talking for almost an hour, and I will stop and take questions.
Just about who are making enough money that they don't get the support.
But they don't qualify.
And their health care is what drops down.
Right. That's actually a problem that used to be more severe, where when Medicaid was restricted really to the poorest people, right? You had sort of really poor kids with health insurance, and then you had a drop off, and then it slowly increased again with income levels. The expansions in Medicaid have modified that, especially with first the Medicaid expansions and then the introduction of S-CHIP, which is the State Children's Health Insurance Program. So that you see, at least in national data, maybe New York's different, you see relatively flat rates of health insurance and then increases as income goes up. You don't see the big dip down that you used to see. It's not much matter. Yes?
Would you comment on why universal health care doesn't seem to do a better job than non-universal health care?
In terms of these income gradients? Well, I think that it's so the question is, why is it the case that we still see these big disparities in health among children as well as adults, even in countries like Britain that have universal health care, right? And that's why I think at the end of my talk, when I come back with these issues, first of all, healthcare quality, because I think there's evidence from Canada and Britain that, wealthier people, and this is maybe a general economic principle, tend to get better no matter what. They're going to find out the best doctors, they're going to be able to pay higher rates and go around the health system. So they may be getting better quality care, more health care, even despite the universal nature of health care. The other thing that I think is really important are these issues of management of healthcare problems, knowledge about how to manage healthcare problems, compliance with medical protocols. So there may just be really big differences across income groups in how well people are equipped to manage health problems that result in large disparities. That's an area where I think we need a lot more work. Because what we need to do is, if that's true, we need to figure out ways to help people who are poor become better consumers of healthcare and learn how to navigate the system better and take care of themselves better. Yeah.
Three quick things. Very much enjoyed the lecture. Second, I couldn't help to think as you were speaking about cost and effect. What I mean by that is, I think you make a pretty good point that people who have lower incomes have all these adverse outcomes. But what cost is the lower income? And what policy implications should come out of that? Because, for example, people who are less educated, who are less diligent, who are less willing to do certain things, have a higher propensity to end up in that lower income. So, has anybody done any work on the root causes of that lower income? And then the second one is, I wonder if you have any data or anybody studied it. Your data regarding people's ability to move from one income bracket into another. If you've looked at, given the society of immigrants that we have in this country, some of those immigrants that come into this country and find a way to get out of poverty, and what are the common denominators amongst those groups that could also have policy implications for helping the broader group to have what we're saying that they have not found.
Okay, let me take the first question first, which is actually kind of a really big ticket question. And there's a lot of people worrying about this, which is, okay, is this really money? And notice that one of my implications wasn't what we should do is have a more progressive tax system because that will solve this problem, right? Equalizing income maybe would make things better, but maybe it wouldn't. And what it depends on is whether it's really the money.
Forgive me for interrupting,
Yeah.
but we know from many European countries that have very high tax brackets, that just by taxing the hell out of people, we're not gonna change these behavior patterns that lead to these problems.
But let me step back, because I think there's sort of two hypotheses. One hypothesis is this really is about money. And if it's really about money, then if poor people have more money, then this wouldn't be, their kids would be healthier, they would be healthier. The other is that it's not about the money per se, but it's about things that go with poor income, go with low income. So people who are poor have lower education, they may have worse health themselves, and so because income is so highly correlated with these other factors, ability, drive, whatever, it's very hard to sort that out, right? Now, so again, this is the kind of place where you'd say we really need some randomized interventions. We need cases where we give people more money and we see what happens, right? Because if it's not money, if it's something else, giving money isn't going to do any good, right? Those types of interventions, actually, people are doing, but they're very expensive, so they're not doing them in this country. So actually, right now, I'm involved in I have this development economist hat to myself, and I'm doing a randomized intervention in Ecuador, where low-income families are actually being given cash transfers, and we're tracing through the effects of that on children's anemia, cognitive development, a lot of different health indicators. So that's the kind of evidence that I think might convince you, right? If I could show you evidence that actually, you take family, you give them money, things get better, right? But in the U.S., I think that's still a fairly open research issue and an important one. There's also a lot of very interesting work, and I don't want to go into it too much in detail because I haven't done it myself, on the health of immigrants and also social mobility of immigrants. So, for example, some of these income gradients in health that I showed you look quite different in immigrant populations. So there's sort of what people call a Hispanic paradox, where a lot of recent Hispanic immigrants have health status that's much higher than it quote should be, given their income levels. One reason why I think it's hard to figure out what's going on, so people talk about differences in culture and differences in community that may be driving differences in success and differences in health. The other thing that people talk about is simply a sort of selection story, where the people who are recent immigrants are people who have a lot of drive, a lot of ambition, they're going to do well, right? And so it's hard from that to draw general lessons for the rest of the population that isn't selected, it's just a population. So there's a lot of research going on in that area. I don't think there are any real solid conclusions right now. Other questions? Yes?
Is it possible